Bismillahirrahmanirrahim. Assalamu alaikum. This is Dr. Waqar from Child Health Matters. So today I will talk about renal pelvic dilatation. This is called RPD in communication station of MRCPCH clinical exam. This is the common scenario. Sometimes you have a medical students who wants to know about the renal pelvic dilatation, and sometimes a mother who has a baby just born or is already or is still not born, but their RPD diameter show in ultrasound shows 10 mm or 15 mm. So how would you communicate what investigation they need and what is the RPD? So before I am going to tell you about the question what role player may ask, I will just talk about the topic what is renal pelvic dilatation. Before I start, just please subscribe my channel so that you can receive a notification for the further videos. So what is renal pelvic dilatation? Usually it is called RPD, and it can be diagnosed antenatally, which usually after anomaly scan, which is at 20 weeks. And if there is a RPD diameter is more than normal, then they have to repeat the anomaly scan. They will repeat the scan at 32 to 34 weeks. So in exam you might have a scenario that 36-week pregnant lady or 37-week pregnant lady, or she is in the labor room, and antenatal ultrasound scan shows RPD of the baby is around 10 mm or it's around 15 mm. So just tell her what does it mean and how would you manage, what investigation that baby has required. So this is very important about to know what is the size of RPD. So there are some abnormalities in antenatally in the renal system of the babies, like renal agenesis. It could be with oligohydramnios or without oligohydramnios. We call it Potter sequence. Multicystic dysplastic kidney, MCDK, and also it could be solitary kidney, and it could be problem in the shape of the kidney, and it could be parenchymal issues. So these are problem can be diagnosed or can be assessed antenatally ultrasound in the mother. So assess the severity of RPD. It's very important. So normal RPD, renal pelvic diameter, which can be assessed on antenatal scan, less than 7 mm, it's the normal. If it is called mild, then it could be 7 to 9 mm, moderate 10 to 14 mm, severe uh, more than 15 mm. So it is important to know about mild, moderate and severe, and also the normal, because if you will get the normal mm of RPD, then your communication answers would be different. Definitely those babies doesn't require any prophylactic antibiotics, any repeated scan, or just they need an observation what symptoms are to observe. But if it is more than 15 mm, their management is different. So in exam scenario you will find only 10 mm or 15 mm or 14 mm. So by this you should know how to discuss with the role player. So in unilateral or it is bilateral. So this diameter is enlarged, it's a unilateral or it's a bilateral. It is also important. So postnatal management, if it is these are the thing which you should memorize. If urgent, immediate and non-urgent. So when it is urgent and when it is non-urgent. If it is, for example, you have a postnatally RPD is more than 10 mm, it's urgent. If it is more than 10 mm with thick wall bladder, we can suspect of PUV in boys. PUV means, as you know, is a posterior urethral wall. So if it is bilateral and unilateral, number one is the if first you should know it's a bilateral or unilateral. Why it is important? Because bilateral, it could be because of PUV, posterior urethral wall, and In scenario, you will find there is a boy. But if it is unilateral and RPD is more than 15 mm, which is a pelvic ureteric junction problem, there could be problem in the PUJ obstruction. So these two things are important. If it is bilateral, more than 10 mm RPD, and wall is thick wall bladder, then it is a P. It could be the PUV, which is posterior urethral wall. If it is unilateral and dilatation is RPD is more than 15, then you can say PUG obstruction. So if any of severe problem, any you find that it could be more than 15 mm or 10 mm, you should check for the potassium, blood gas, and serum creatinine for the renal insufficiency. They might have renal insufficiency if they have that much of RPD. So all others abnormalities of urinary tract and anterotal skin are the non-urgent cases. So they don't need any urgent intervention. So urgent intervention only when there is a bilateral or unilateral RPD more than 10 or more than 15 mm. So I will let you know about the subsequent management. What is the subsequent management and immediate management? So what is the immediate management? You find the child has a bilateral 10 mm of RPD or unilateral more than 15 mm of RPD. So how would you manage? What is the immediate management? This is the important thing in the communication scenario. So immediate management of PUV and PUJ, posterior urethral valve, and pelvic ureteric junction obstruction. Arrange urgent KUB ultrasound scan within 24 to 48 hours. So usually they are saying it's better to do before you feed the baby. It can affect the scan. So 24 to 48 hours. But if it is mild in feeding, it doesn't affect. It does not affect within 24 hours. So it's okay to feed, but less amount. So if it is PUV, posterior urethral valve, dilatation of ureters and thick wall bladder, serum creatinine and arrange urgent MCUG, which is micturating cystourethrogram. So now you have two scenarios. One is PUV, other is PUJ. PUV, posterior urethral valve, you will find the bilateral and thick wall bladder on the ultrasound scan, and in that scenario you should have to do MCUG, micturating cystourethrogram. But keep in mind, these investigations are by the subspecialty, by the nephrologist, by the urologist, sorry, by the urologist, not by you. So you should have to tell them, discuss with the urologist for the MCUG. If it is unilateral RPD more than 20 mm, this is a very huge amount of dilatation, more than 20 mm. So PUG obstruction, arrange MEC 3 renogram. So this is, you have to arrange only by discussion with the urologist. You are not one who is at the junior level, you will do the MEC 3 renogram with your decision. No, you will do the investigation, you will do the ultrasound KUB, but you will make the other investigations like MCUG or MEC 3 renogram. You have to discuss with the pediatric urologist. So this is a huge obstruction, so they need the, so start trimethoprim 2 mg per kg single dose at night if the significant abnormalities are, you have doubt of renal insufficiency. And then you, as I told you, you have to do the blood gas, metabolic, to look for metabolic acidosis, serum creatinine, and serum potassium as well. And you have to start trimethoprim 2 mg per kg as a single nighttime dose. There are some contraindications, like the patient who has G6PD, you are not supposed to start trimethoprim. So other cases, if it is significant abnormalities, you have to start antibiotic trimethoprim, which is 2 mg per kg. And after that, in non-urgent cases, all non-urgent cases, they need ultrasound, renal ultrasound scan at the age of 2 to 6 weeks, and then you will give an appointment. This is very important, which I am telling you now in communication scenario in exam. If you find that it is non-urgent, if it is 7 mm of dilatation of RPD, So this is not urgent. So you will not tell them that we will do all investigation. No, you will tell them about the symptoms, that any oliguria, any urinary symptoms, any signs of UTI, then they should bring to the emergency or to the doctor. Otherwise, you will give an appointment of ultrasound scan at the age of 2 to 6 weeks, and then appointment for the consultant, which is pediatric urologist. Okay, then the subsequent management, it was the immediate management for the urgent cases, as I told you about urgent and non-urgent. Then the subsequent management according to the RPD. So if it is normal or mild isolated pelvic means pelvis is, you know, I will show you the picture at the end, and in renal pelvis, if it is dilated, we call it ectasis. So pelvic ectasis and RPD is less than 10 mm. So how would you manage in this scenario? So this is the mild, and in this case you had antenatal ultrasound scan which shows 10 mm or more than 10 mm, and you started antibiotic, and you repeat and KUB ultrasound after 2 to 6 weeks, after a few weeks of birth. Then you find that RPD is less than 10 mm and it is isolated pelvic ectasis, which is mild. Then you should stop the antibiotics prophylaxis and repeat scan after 6 months. So repeat scan after 6 months. If it is RPD less than 10 mm, no need of prophylaxis antibiotic. If 6 months scan normal shows no change and no UTI, you can discharge from the clinic. This child is normal. No, only just observe at home for the signs of UTI. Okay, so the other thing is the moderate unilateral pelvic ectasis. Pelvic ectasis means dilatation of the pelvis. So moderate unilateral pelvic ectasis, RPD 10 to 14 mm. This is the moderate, and severe pelvic ectasis RPD is more than 15 mm. So in moderate cases, subsequent management, if it is dilatation, then presumed mild obstruction or VUR. If RPD increases beyond 15 mm, arrange MAC3 scan renogram, which you know more than 15 mm, MAC3 renogram. This is for sure. So continue prophylaxis for vesico-ureteric reflux, which could be grade 4 or more. It means until child is out of nappies. Until child is continent, then until that you have to give the prophylaxis of for the UTI, and this is they might have the VUR. Okay, so these things, and you will arrange the MAC3 scan, and you will refer to the child to the pediatric urologist. So this is the subsequent management of unilateral pelvic ectasis if RPD is more than 14 mm. So in severe cases, arrange MAC3 scan immediately, and the timing depends on the, if possible more than 20, definitely it's urgent. Obstruction pattern could be discussed with the pediatric urologist. If more than 15, you should arrange immediately MAC3 scan. Definitely you will do the KUB ultrasound, you do the metabolic what means blood gas, potassium. So these things definitely you will do, and after that you will arrange for the MAC3 scan and discuss with the pediatric urologist if it is more than 15, especially if it is more than 20 mm. Repeat ultrasound scan at 3 to 6 months depending on the cause of dilatation. A complete obstruction requires close monitoring. Okay, and this at this stage they need the continuous prophylaxis antibiotics. So these are the three things which you should have to know about the diameter of the RPD, and according to this diameter of the RPD you have to tell the management, because examiner wants to know either you know about the RPD or not. You know the diameter size. If this diameter is 10 mm, if it is more than 15 mm, then how to manage. If it is less than 10 mm, then how to manage. So these question role player might ask, so you should aware of the management of these things. So one is a mild isolated pelvic ectasis, RPD less than 10 mm. Only they need no need a prophylaxis antibiotic. Repeat scan after 6 months. So number 2, moderate unilateral pelvic ectasis, RPD 10 to 14 mm. In that case, yes, you should have to arrange for the MEC 3, and prophylaxis you should have to continue. And in the case of severe, in this case, urgent arrangement of MEC 3, and definitely you will discuss with the pediatric urologist and continue antibiotic prophylaxis. So let's discuss about the question what role player might ask from you when you are in the communication station. If it is a pregnant mother about to deliver a boy or a baby, any boy or girl, and you have a scenario, then she might ask you what is renal pelvic dilatation. So it is the renal pelvis is the area of your baby's P system, which is called the kidney. So before, if you will tell them about the kidney, ureter and the bladder, it would be easy. Draw some drawing as well. I will show you the drawing in the next slide. So area of your baby's kidney where the urine is collect, where the pee is collects there in the kidney, in the center, that is called the pelvis. So renal pelvis looks wider, more dilated than usual on the ultrasound scan or the jelly scan or the sonograph. Then we called it the renal pelvic dilatation. Okay, how it is diagnosed? So usually at 20 weeks of pregnancy we have anomaly scan. At that scan we find that their RPD, the renal pelvic size is increased. That's why we are saying it is a renal pelvic dilatation. And scan show more fluid in there at this area. You will drawing the picture of the kidney and you can say it's a more fluid at this area. Okay, so what does it mean for your baby? Or for example, how what does it mean for your baby? And now definitely mother would be worried, what will happen? Is my baby has renal failure or not? It can be a normal variation. You can just give them a support. It can be a normal variation, yes, it can be, or it can be associated with some degree of blockage in the P system or urinary tract system, like the kidneys, ureters, urethra or bladder. And sometimes some babies have a backflow, which we call it reflux, so which is the VUR. So there are two things, obstruction and VUR. So you will take, it could be normal variant, it can go by itself, and sometimes it can affect blockage of the obstruction, means kidney, kidney, ureters, urethra and bladder, and sometimes it is a backflow of the urine, which is called reflux. Further investigation, here you need guidelines when you should have to do the further investigation. If it is mild, no need of prophylaxis antibiotic, no need of anything, just observation, maybe to repeat the scan after a few weeks, and if it is normal, that's it, you can have to discharge. But if child is symptomatic with the UTI, definitely you will go for the investigation for UTI. Okay, how can renal pelvic dilatation affect my baby? As I told you that it can, if it can be normal variant, it can, some babies can go out of after neonatal period. Sometimes they might have the urinary tract infection, they might develop the fever, they might develop the frothy urine, they might develop the vomiting and tummy pain, and they might pass the pee and they have the pain, means dysuria. So these things you have to tell the mother about the UTI symptoms. How can pelvic dilatation be treated? As we discussed early, treatment and investigations, antibiotic prophylaxis, and then you will observe for the UTI, and we will refer to the pediatric urologist. What further pregnancies? Yes, this is a common question they ask in every almost in every scenario which is related with the early issues with the neonates. So this, if it is isolated and it is no other abnormalities, then there is a low risk of recurrence. But definitely we will screen you, like in the first this pregnancy we will screen by the anomaly scan. If there is anything, we will intervene definitely. So what happened next? Next you have to arrange an ultrasound after a few weeks of life, after a few weeks, to look for the renal pelvic and to look for the size. If it is 7 or less than 7, then no further follow-up is needed. Then only you have to advice, and you will give the leaflets, and you will give the about trusted websites, and that's it. So this is the diameter. If you will see, this is the renal pelvis, and this is dilated. We call it renal pelvic ectasis, and VUR, it could be here could be the reflow. This is a one-way wall here, and if this wall will affect, we call it vesico-ureteric reflux. Urine can go backflow. Otherwise, this is the one-way wall. And urethra, if it is a boy, then it could be the posterior urethral wall. If the blockage at the urethra, definitely you will find the dilatation of the both pelvis, right? So as I told you earlier, if dilatation is of both pelvis, and bladder wall is thickening, it is a posterior urethral wall, PUV. If it is unilateral, then it could be PUJ, posterior urethral junction problem. So these are the things you should know, and if you will draw a picture in the exam, it will also give you some marks. Thank you very much. So for the mock exam of MRCPCH, you can contact me on my email, and it will help you, it will give you the confidence to pass in the first attempt. Thank you very much.